Hey guys, welcome to another presentation of the pathology series. My name's Ria and I'm a fourth year medical student. Today I will be covering the topics of valvular disorders, endocarditis, cardiomyopathy, and cardiac tumors. These are quite big topics in CVS, which is also a very important topic in pathology. So I hope this presentation will make certain concepts and diseases a lot easier to understand. So this is just an overview of the different types of valvular disorders we have, types of endocarditis, and different features which we will go through in more detail when we get to that slide, the different types of cardiomyopathy, and the types of cardiac tumours. I've tried to include the most high-yield information in this presentation, which is crucial for you to know when you're studying for pathology. So starting off with valvular disorders, there are different types, and I'd like to start off with acute rheumatic fever. Now, before we talk further about, what this disease is and clinical features, whatever topic you get in your pathoanat exam or in general when you're studying, it's very important to structure your answer into, first of all, what is the disease? So a brief definition, and then if you remember anything about the epidemiology, so who is it mostly targeting? Then talk about the pathogenesis. The professors would love to hear about, how the disease is developing. It's then important to talk about clinical symptoms, microscopic analysis, and macroscopic features if it's relevant. Obviously, you don't have to follow this exact order, but yeah, it's important that you take into consideration these different aspects of each disease, and that way it'll make it more manageable for you to understand and remember certain facts. So, acute rheumatic fever, what is it? It's basically a complication of a group A beta hemolytic strep infection, which you have studied already in microbiology when you have pharyngitis due to group A strep. It's an acute, non-purulent, immune-mediated systemic inflammation, so it's affecting the entire body and it has tendency to relapse. The most commonly affected organs are the heart, the joints, the skin, and the CNS. It most commonly affects children between the age of 5 to 15 years, and the incubation period is usually 2 to 3 weeks after an infection with strep pyogenes pharyngitis. Now, in terms of pathogenesis, it's an autoimmune reaction. So, as you can remember from microbiology, strep bacteria, they have antigens on their capsule. This is the M protein, and this M protein is recognized as foreign by our body, and hence, just like in any other immune reaction, there's formation of autoantibodies, which is going to cross-react with the antigens in our heart. So due to this cross-reaction, we call it a type 2 hypersensitivity reaction, and that's because this M protein is exactly mimicking the myosin of our heart. So, if you're asked in a nutshell, the pathogenesis is to do with molecular mimicry. Now, moving on to the clinical symptoms of rheumatic fever, a very useful mnemonic that will stick in your head to help you remember is the Jones criteria. J is for joint problems, and that's because rheumatic fever is attacking the joints and it can cause migratory polyarthritis, so it's moving from one joint to another. The O is basically for the shape of the heart, and that's because it's causing pancarditis, which means all the three layers of the heart is affected: pericardium, endocardium, myocardium. So the patient will have endocarditis, and a major complication of this is mitral regurgitation. We'll talk more about it in detail later, but yeah, this is because endocarditis can cause rupturing of the valve, and that can lead to backflow of blood from the ventricle into the left atrium. It can also manifest as myocarditis, and what's very typical, and you cannot forget this term, are your Ashraf bodies. You might have seen it already in your pathoanat classes. This is basically an area of chronic inflammatory cells with giant cells, areas of fibrinoid necrosis, specific types of caterpillar cells called the Anichkau cells. These are basically histiocytes with quite wavy nuclei, and pericarditis as well, and that can lead to a friction rub. N is for nodules, so the patient typically has subcutaneous nodules. They tend to have a pink or light red rash, E being for erythema marginatum, S is Sydenham's chorea. This is when the patient has quite rapid involuntary movements of the limb, the neck, the head, or face, and that's because it's affecting the basal ganglia or the brain. And what's important to note is that it may progress to a chronic disease and relapse, as I mentioned in the first slide, and that's because if the patient has a repeated exposure to group A beta hemolytic strep, it leads to the relapse. Now, in terms of microscopic diagnosis, what is the basic morphological lesion for rheumatic myocarditis is Aschoff's nodules, as you can see in this picture on the right. It is not a sign of disease activity, it's diagnostic. What this is that you will see an area of light fibrinoid necrosis, and this is filled with collagen fibers as well as cellular infiltrate, and they're basically spindle-shaped deposits within the interstitium. Where do we find them? It's usually along the intramyocardial vessels within the fibrous septa. And there are 3 phases to these nodules which you should be aware of. Is the exudative phase. This is area of necrosis, neutrophils, lymphocytes, macrophages, and histiocytes. In the proliferative phase, this is where we have the modified histiocytes, i.e. the Aschoff cells. As we can see on the picture, each Aschoff cell has multiple nuclei. It's basophilic, around 2 to 3 nuclei, and we can also see the Anichkow cells, as I mentioned before. These are smaller compared to your Aschoff cells, and they have more centrally condensed chromatin and the wavy nucleus, which resembles a caterpillar, so hence caterpillar nucleus, and Anichkow cells. And we will also see lymphocytes and fibroblasts. And then the healed phase is basically the phase in which there is formation of a perivascular scar. So you might have seen this already in your slide in the pathoanat classes, but if not, look at this picture, and I really recommend you guys to look at more slides online for Aschoff nodules just to get an idea as to what it looks like. Now moving on to chronic rheumatic heart disease. Acute rheumatic fever can actually progress to chronic rheumatic heart disease. So it's a consequence of rheumatic fever over time with scarring of the valves. What's typical is that you see a fish mouth appearance of the valves, which most commonly affects the mitral valve, as you can see in this picture. There will also be thickening of chordae tendineae and valve cusps. It can also affect the aortic valve, but less frequently, leading to commissural fusion, and a major complication is infective endocarditis. Okay, so now moving on to the most common valvular heart disease present in industrialized countries is aortic stenosis. So what is aortic stenosis? So first of all, the aortic valve is found between the left ventricle and the aorta, and if there's stenosis of this valve, it's going to lead to a tighter and narrower orifice, and this is going to obstruct the flow of blood from the left ventricle into the aorta. If you imagine a lumen, if it's narrower or smaller, passage of anything through that lumen will be more difficult, and this is similar for aortic stenosis. And this can actually lead to left ventricular failure. Major causes of aortic stenosis involve sclerosis of the aortic valve. So over time, fibrosis and calcification of the valve leaflets due to wear and tear can cause fibrosis and dystrophic calcification. It can also be caused by chronic rheumatic valve disease, as well as a bicuspid aortic valve where 2 out of the 3 leaflets are fusing together in utero. So this is a congenital problem. It typically affects patients who are older than the age of 60, since the aging process is going to increase wear and tear and is going to increase fibrosis of the valves and lead to valve degeneration. So if you're asked about, what are the major risk factors for aortic stenosis, aging is number 1. It can also be due to the bicuspid heart valve, patients with diabetes, high cholesterol, and hypertension. In terms of pathogenesis of aortic stenosis, we said that the valve orifice is a lot narrower during systole, and so blood is not going to be able to flow as effectively from the left ventricle into the aorta, so there's going to be increased left ventricular filling pressure. It's going to build up, and this is going to increase the left ventricular pressure, causing left ventricular concentric hypertrophy, which is an adaptive mechanism. And this leads to increased oxygen demand. There's impaired ventricular filling during diastole, leading to left heart failure. Initially, your cardiac output can be maintained. However, later, there is decreased distensibility of the left ventricle because so much blood is trying to pool in that left ventricle. And that's going to reduce the cardiac output, leading to pulmonary congestion. It's going to cause backflow of blood into pulmonary veins and the capillaries, causing a higher afterload on the right heart, and thus leads to a right-sided heart failure. So clinical features of aortic stenosis you can remember with SAD, S for syncope, A for angina pectoris, and D for exertional dyspnea. Other features are weak delayed pulse, harsh crescendo, decrescendo murmur. Next, we have aortic regurgitation, in which there's backflow of blood from the aorta back into the left ventricle, typically during diastole. And major causes are due to aortic dissection or a syphilitic aneurysm, in which there's dilatation of the aortic root, and that causes the backflow of the blood. It can also be due to valve damage, such as in infective endocarditis, when you've got vegetations depositing on the valve, and that itself can cause damage to the valve and lead to backflow of blood. Clinically, you will be able to auscultate an early blowing diastolic murmur, increased pulse pressure leading to hyperdynamic circulation, and there will also be dilation of the left ventricle, and that's because there is pooling of blood into the left ventricle from the aorta backwards, and there will be eccentric hypertrophy. Treatment is replacing the valve. Mitral valve prolapse is when there is ballooning of the mitral valve into the left atrium during systole, and it's usually caused by myxoid degeneration of the valve, and this causes a very floppy type valve, causing ballooning. And this is typically seen in two important conditions, Marfan's and Ehlers-Danlos syndrome. Clinically, you will hear a mid-systolic click, regurgitation murmur, which increases with squatting. Patient typically suffers from palpitations, fatigue, dyspnea, and dizziness. Complications of mitral valve prolapse is infective endocarditis, arrhythmias, and severe mitral regurgitation. In mitral regurgitation, blood is being refluxed from your left ventricle back up into the left atrium during systole, and this can be caused by numerous different diseases, one of them being mitral valve prolapse. When we said the mitral valve can actually balloon into the left atrium, it could be caused by left-sided heart failure, infective endocarditis, acute rheumatic heart disease, and even after myocardial infarction when the papillary muscle ruptures. So clinically, what's typical is that there will be a hollow systolic blowing murmur, which is louder with squatting and expiration, and typical other features such as dyspnea and fatigue. Another important valve disorder is mitral stenosis. What's happening here, once again in stenosis, as we said before when we were talking about aortic stenosis, is that there is narrowing of the valve orifice. Here it is the narrowing of the mitral valve orifice, and that's because there has been commissural fusion of the leaflets, and as we can see from the picture on the left, it resembles a fish mouth appearance, and that's a very important term to remember and associate with mitral stenosis. Some typical causes are, it could be autoimmune, it could be due to systemic lupus, it could be due to chronic rheumatic valve disease, rheumatoid arthritis, or it could just be congenital. Now, in terms of pathogenesis, if there is stenosis of the mitral valve, it's going to obstruct flow of blood from the left atrium into the left ventricle. And so less blood will pool into the left ventricle, which decreases diastolic filling. There will be decreased end diastolic left ventricular volume, and if there's less filling of the left ventricle, there will be a decreased stroke volume, which is going to further decrease cardiac output and perfusion of organs and hence lead to forward heart failure. It can also cause backward heart failure, and that's because if blood is unable to move into the left ventricle, it's going to stop pooling up within the left atrium. And this is going to increase your left atrial pressures, and this leads to backup of the blood back into the lungs, into the pulmonary circulation. So it's going to increase the pulmonary capillary pressure, leading to cardiogenic pulmonary edema and pulmonary hypertension, leading to backward heart failure and right ventricular hypertrophy, because the right side of the heart now has to pump against a greater resistance. So major complications of mitral stenosis, as we said, due to backflow of blood into the pulmonary circulation, it can cause pulmonary congestion, leading to increased hydrostatic pressure in capillaries, causing edema and alveolar hemorrhage. And you will see quite engorged capillaries, which can rupture. And as they rupture, the macrophages are then coming in and they're eating up and consuming this blood. And so what's typical is that you will see hemosiderin-laden macrophages / heart failure cells. It can also cause pulmonary hypertension, and that's because there's backflow of blood into the right side of the heart. So the right side now has to pump against higher pressures, and this can lead to right-sided heart failure. It can also cause atrial fibrillation. Why? Well, because in mitral stenosis, as we said, blood starts to pool in that left atrium, and the stasis of blood increases risk of mural thrombus. Remember, in the virtuous triad, one of the major features is stasis. So yeah, there will be a thrombus formation, and this can actually go into the systemic circulation, such as the brain. And this is really important. You could be asked this in the final, why atrial fibrillation occurs with mitral stenosis and where is it going to affect mostly. So clinical features, patient will have dyspnea, that's because there's buildup in the lungs. So PND, paroxysmal nocturnal dyspnea, it can cause orthopnea, hemoptysis, dysphagia, because enlarged left atrium can compress your esophagus, a mitral face, which you can see in the picture, atrial fibrillation, and histologically we will see these hemosiderin-laden macrophages caused by engorged capillaries which rupture. So that was it for the valvular disorders. I really recommend you guys to go through Pathoma. It always uses the high yield information that you need to know. So go through that, go through the presentation for the valvular disorders and try to understand, try and correlate why that disease happens and how it's affecting and developing. What is the pathogenesis? And it makes it a lot easier to understand that way. Anyway, moving on to endocarditis. Infective endocarditis is basically when there's an inflammation of the endocardium. We know the endocardium is lining the inner surface of the cardiac valves. And when there's this inflammation due to a bacterial infection, we have deposits of vegetation. It's a very severe and lethal disease. And the most common bacteria that can cause it is Staph viridans. This is the most common cause. So actually, it is a low virulence organism. However, it has the potential to infect valves which were previously damaged, for example, due to a mitral valve prolapse, artificial valves, or chronic rheumatic heart disease. So it results in small vegetations which are not destroying the valve. Infective endocarditis can also be caused by Staph aureus. This is actually the most common cause in IV drug abusers, patients who have pacemakers or prosthetic valves. We know that Staph aureus is a highly virulent organism and it infects healthy valves compared to Staph viridans. And it results in large vegetations which can actually destroy the valve, and it's fatal within 6 weeks if it's left untreated. Staph epidermidis, this also causes endocarditis of prosthetic valves, and the major way in which it enters through the body is via valve surgery or an IV catheter. And you also have the Hatchek organisms which can cause it. The valve which is most frequently affected is in this order, as you can see on the screen, with mitral valve being the most commonly affected. So this is the list of the risk factors for endocarditis, being male, age, having an acquired valvular heart disease such as rheumatic heart disease or aortic stenosis. Prosthetic heart valves can increase the risk, having a congenital heart disease, dental procedures, especially patients who are immunocompromised, patients undergoing surgery or IV drug use. So it can be of two types, iatrogenic or nosocomial. Now, understanding the pathogenesis of infective endocarditis is very important. So imagine if you have a valve that has been previously damaged by, for example, rheumatic heart disease or mitral valve prolapse. There will be a damaged endothelial surface, and we know usually if the endothelial surface is intact, there is no, aggregation of platelets. However, if it's damaged, subendothelial collagen will be exposed as well as the tissue factor, and that leads to adhesion of the platelets and fibrin, and this leads to non-bacterial thrombotic sterile vegetations. If there is a infection or contamination, however, such as with bacteremia after a dental procedure or open wound, bacteria will start to colonize within this vegetation. It's the perfect niche for the bacteria to grow, and this forms a biofilm leading to infective endocarditis. Major consequences is that we can have bacterial thromboembolism causing occlusion of vessels and infarction. This can be really lethal. The emboli can also affect other organs by spreading. There can be septic embolus or central pyemia. The top clinical features are high fever, chills, patient complains of night sweats, weight loss, dyspnea, cough, and some other high yield terms to know, which are clinical manifestations, are Janeway lesions, splinter hemorrhages, and Osler nodes, as you can see in the picture below. In terms of lab results, since it's an infection, bacterial infection, the CRP count will be raised as well as increased leukocyte count, and there will typically be microcytic anemia with low hemoglobin levels. Diagnosis is with auscultation, blood tests, blood culture, hemoculture, ultrasound in which you will be able to see the vegetation, and you can do two types, chest and intraesophageal ultrasound, as well as transesophageal echocardiography to measure your size of the vegetation. In terms of treatment of infective endocarditis, it's very important to have prolonged antibiotic, and severe cases, surgery might be required. For patients who are treated, only a third will die, so the mortality rate is quite high, and a third will survive without an ill effect, and 1/3 survives without valve damage. And the antibiotic therapy that is typically used for infective endocarditis is vancomycin for 6 weeks or ampicillin and gentamicin for 4 to 6 weeks. Not something you need to know right now since it's pharmacology, but yeah, in case someone wanted extra information. Now, what is NBTE? Non-bacterial thrombotic endocarditis is different to infective endocarditis. It's in the name. Here we have sterile vegetation, so it's not been infected with bacteria. It's found on the surface of the cardiac valves, it's non-infectious, and the main composition is platelets and fibrin. We can have different types. One is cachectic endocarditis, typically affecting cachectic patients, and it can be associated with paraneoplastic syndrome or a hypercoagulable state. Once again, the mitral valve is most commonly affected, and you might be asked which tumors are most frequently associated with NBTE, and these are ovarian, stomach, pancreatic, and lung adenocarcinoma. Major complication is embolization, and we also have Libben-Sachs endocarditis. This is a special type of endocarditis, and it occurs due to sterile vegetations, typically associated with patients with systemic lupus, and it can lead to mitral regurgitation. Please remember Libben-Sachs endocarditis. I know they love to ask about this. Moving on to cardiomyopathy. This was actually a topic I personally found hard because there was a lot of features going on and it's important to understand it. So what is cardiomyopathy? It's a broad term basically. It's referring to a heterogeneous group of myocardial diseases which can lead to severe cardiac dysfunction, and it can be divided into dilated cardiomyopathy, hypertrophic, or restrictive. If we have dilated cardiomyopathy, all 4 chambers of the heart are dilated, typically the left ventricle. So if it's dilated, it leads to hypertrophic ventricles with increased weight. You don't need to necessarily learn the value, but just know it in case. So dilated cardiomyopathy is the most common form of cardiomyopathy, and it's caused by a primary damage to the myocardium, to which the heart is going to respond by dilation primarily. Hypertrophy is secondary, and this is quite a high yield fact, so remember that. Risk factors are alcoholism or having a previous family history of cardiomyopathy. The most common causes are actually idiopathic, so there is no known reason as to why it happens. It could be due to a viral infection with Coxsackie A or B virus, which leads to infiltration of lymphocytes, genetic mutation, alcohol abuse, typically associated with beriberi, anti-tumor drugs such as doxorubicin or anthracycline, or pregnancy. So histologically, we will see non-specific hypertrophy as well as mural thrombi within the apex and auricles. Clinically, patients will have dyspnea, fatigue, edema within their legs, ankles, feet, chest pain. Major complications is that, imagine if so much blood is building up in the ventricle and it leads to dilation of the ventricle, this is going to cause stretching of the heart, and this is going to weaken the contractile function over time, causing systolic dysfunction. The heart won't be able to pump the blood as effectively, and that leads to biventricular congestive heart failure, so both the left and right side of the heart are affected, leading to mitral and tricuspid valve regurgitation. This is another complication, and that's because as the heart is stretching, it's also stretching the valves. So in this case, the mitral and tricuspid valve annulus, that ring is going to stretch, it's unable to close, and that leads to regurgitation as well as arrhythmias. Diagnosis is with X-ray as well as biopsy, and treatment, patients typically would require a heart transplant. Hypertrophic cardiomyopathy is massive hypertrophy of the left ventricle. It's asymmetric and it's typically affecting the interventricular septum. Ratio of men to women being affected is quite equal. It's usually caused by a genetic mutation of the beta-myosin heavy chain, which is a very important myocardial sarcomere protein, and it's familial in 2/3 of cases. Clinically, if the heart is hypertrophic, decreased cardiac output, and that's because left ventricular hypertrophy will lead to diastolic dysfunction, and the ventricles cannot fill as properly. It can cause sudden death due to ventricular arrhythmias, and it's very important to note that HOCM, hypertrophic cardiomyopathy, is actually the most common cause of sudden death in young athletes. It can also cause syncope, typically with exercise. There is subaortic hypertrophy of the ventricular septum, leading to functional aortic stenosis. Microscopically, for hypertrophic cardiomyopathy, we will see quite disorganized cardiomyocytes going in different directions. There's no proper array. There is a disarray, in fact, and they're of an irregular and bizarre shape. So we will see myofiber hypertrophy with disarray, as well as interstitial fibrosis. You can diagnose usually with ultrasound or biopsy, and treatment is usually with beta blockers or calcium channel blockers. We also have another type of hypertrophic cardiomyopathy, and this is obstructive. What's happening here is that your mural endocardium is thickened, and this is in direct contact with the septum in systole, leading to SAM, systolic anterior motion. And this SAM can cause a dynamic outflow obstruction of left ventricle, which means the blood is being forced through a very, very narrow opening, and that causes an obstructive hypertrophic cardiomyopathy. Lastly, we have restrictive cardiomyopathy. Here, there is decreased ventricular compliance, so there will be restricted filling with blood during diastole, and it leads to reduced cardiac output because not as much blood can fill the heart ventricles, and it's usually caused by amyloid deposits, sarcoidosis, hemochromatosis, and the Loeffler syndrome. And in terms of pathogenesis, we have a very stiff and rigid myocardium, so this is going to impair the filling of the ventricles. Ventricle isn't filling as properly, leading to diastolic dysfunction, reduced ejection fraction, and hence right-sided heart failure. Microscopically, we will see interstitial fibrosis as well as amyloid. This typically looks quite red and pinkish. Clinically, patients suffer from diastolic heart failure, dyspnea, crackles, orthopnea. And last but not least, we have the cardiac tumors. First is myxomas. Myxomas are the most common primary cardiac tumor found in adults. What it is it's basically a benign mesenchymal tumor with a gelatinous appearance, and it's got a lot of ground substance on histology. It forms quite a pedunculated mass within the left atrium, and this is easily seen on imaging, as you can see on the right picture, and this can lead to syncope due to obstruction of mitral valve. We then have a rhabdomyoma, so this is actually a benign hamartoma of cardiac muscle. A rhabdomyoma is the most common primary cardiac tumor found in children associated with tuberous sclerosis. and it usually arises within the ventricles. So myxomas and rhabdomyomas are your two most common primary cardiac tumours, and then we have metastasis. Metastatic tumours are much more common than your primary tumours in the heart, and you might be asked which carcinomas are commonly spreading to the heart. The top four you should know are lung, breast, melanoma, and lymphoma, and it commonly affects the pericardium, leading to buildup of fluid accumulating, leading to pericardial effusion. So yeah, that was it for the valvular diseases, endocarditis, cardiomyopathy, and cardiac tumours. I did try my best to include all the high yield information and highly recommended sources. I'd say number one, Pathoma. Definitely go through the videos, use the book, and for further understanding, especially for CVS, you might want to use Robbins if you have time. However, it's not necessary. It is just the recommended literature for pathology. Osmosis is very, very good, and this is more for, I'd say, last minute revision and just trying to summarize everything together, because the videos can be very concise and really great to learn from. Or even Amboss. Amboss divides everything well into etiology, pathogenesis, clinical features, epidemiology, microscopic, etc. And I also recommend you guys to use the Sokol pathology videos online. I think he's from Masaryk University, and he has annotated videos on different pathological slides, and this was very, very useful. So yeah, if anyone has any questions about this presentation, you can always message me or send me a message on WhatsApp or on Instagram, whatever. So yeah, good luck for your Patho and App final. I'm sure you guys will ace it. It's a big one, but study wisely, study from before. It's not something you can cram. And yeah, pay a lot of attention to all the topics. However, CVS is very, very important, especially for Professor Steiner, because it's his topic, so go through his lectures if you can. And yeah, good luck.